Thank you so much, Ashwini. That was a very excellent talk. You've done half my job actually. So, good afternoon to the august audience, my seniors. You've been a lovely audience here, very informed questions and discussions have taken place. My job is to concentrate on the RAMI, which involves basically three portions of the operation, which means the thoracic part, the abdominal part, and the neck part. I think the laparoscopic part or the abdominal part and the neck part are more or less covered here. I'll probably skip over those or at least run them through. But I concentrate on trying to do exactly the same steps as Ashwini has shown you, except I'll try to break them down into steps so that it makes more sense. Otherwise, the operation is a very confusing operation because the surgeon has a huge field to run through and he keeps on juggling from one to the other without describing exactly what to do. No conflict of interest. Patient positioning, well, there are three ways to do it. When I started my minimal access journey was in lateral position, and then we moved when Dr. Prannalu's paper was published somewhere around 2005-06, we moved to prone position and we stuck to prone position. Now, would I move to semi-prone? For a newer audience, I would say yes, because it gives you some leeway to convert. The prone position does not give you any leeway to convert in case of a catastrophic event happening. Important things, single lumen endotracheal tube. Again, for the newer audience, I would again say that in the beginning of your experience, do not use a single lumen tube, use double lumen tubes so that you have the option of ventilating the two lungs separately if required. But the operation can easily be done with a capnothorax in one side, a pressure of 6 to 8 millimeters of mercury. Equipment required, we need robotic instruments. We use these, bipolar Maryland, monopolar scissors and a suture cut needle driver. In addition, you need some laparoscopic instrument because there is an assistant port there. It is after all a robotic-assisted surgery. It cannot be a robotic alone surgery. So you need a good grasping forceps, which is long and short. A locking clips, that's what we use for most of our azygos. We don't waste time in the suturing and tying of the azygos. Works very well, works very quickly. And a laparoscopic suction that is required. Ultrasonic shears are optional. More or less, the 99% of the work is done with bipolar and the monopolar scissor of the robot. Important things here. There have been times where we turned the patient around and I was not in the OR and something was disconnected. Now remember, in addition to the patient being prone, in the robotic surgeries there is another big patient console over the patient. So if the anesthetist wants to check a line under all that mess, it's a horrendous kind of a thing. You may have to actually stop the operation, undock the robot and then ask her to check the arterial line which is under somewhere there. So please make sure after you turn the patient around that all lines are working. Broadly, these are the steps of the operation. I'll go through one by one. They need not be in sequential order though. So this is the kind of patient we usually see. Those are the ports I use. This is the prone position. Now the broad difference between the semi-prone and the prone is that right hand port. In the prone position it goes medial to the scapula. In the semi-prone it goes lateral to the scapula or anterior to the scapula. Broadly that is and that's where your right hand approaching the mediastinum changes. The assistant port is somewhere there. Important in robot is to know where your assistant port is going to be placed because sometimes if it's not placed properly, the assistant is poorly positioned in view of clashes of the external and the internal instruments. Broadly when you start, this is what you should see. This is from VAT Sira, just to show you anatomy. This is the mediastinum you should be seeing, broadly speaking. And that's what you see in robotic also. This is the view. You are good to start and go, but this is not always the case. That's where the next slide comes in. I have always used and I teach my residents to not only look at the CT scan for staging the disease, but also to look at surgical access. And gradually they have got tuned to look at the lung, especially the right lung, to try to predict what kind of adhesions there will be. And you will see a few examples of how we can go wrong and get into trouble. So this is one of the patients, and this is the video of that patient.